Welcome to High Truths on Drugs and Addiction, where national experts bring you facts and answer your questions. I am your host, Dr. Ronit Lev, an emergency and addiction doctor who has served at the White House and still practices on the front lines. Right here on High Truths, you will learn from experts, hear stories from the emergency department, and listen to people who have struggled from addiction. Friends, fentanyl is plaguing America. It has infected all illicit drugs, from cocaine to meth, counterfeit pills, and even marijuana. If you're around someone who may be using drugs, you should carry naloxone, the opioid reversal agent. Carrying naloxone for drugs is like carrying an EpiPen for allergies. If you need a prescription for naloxone, you should have one. No questions asked. That is why I am offering a free prescription to anyone who needs one. Come visit me on hightruths.com to learn more about the show, submit a question, or download a free prescription for naloxone. And if you like the show, do me a favor. Give us a 5-star review and subscribe. Your stars are very much appreciated and go a long way in supporting the program. This week's episode would not be possible without the generous support from our sponsors. A sincere and warm thank you to CCR, Center for Community Research, enhancing public health and safety through informed action. Hello again at High Truths, and a very special episode with Admiral Rachel Levine, the 17th Assistant Secretary of Health and 4-star Admiral in the Commissioned Corps. Thank you for joining me. I know you could be listening to all sorts of podcasts or watching movies or reading a book, and you chose High Truths, and that means a lot. But before bringing on the Admiral, who will share with us the United States federal strategy for the drug crisis, I thought I would share with you the LEV strategy for the drug crisis. If you've listened to this show, you learn that I get jealous very easily. I suffer from FOMO, fear of missing out. I envy gonorrhea and chlamydia. I covet Shigella diarrhea, and I really, really want to copy COVID. The COVID control model at the beginning of the pandemic followed test, treat, trace. First, test. Stick that Q-tip up your nose and find out whether you have COVID. This was important because the test was positive before you had symptoms. The test resulted in complex mapping that we saw go across the globe, this surveillance, and we had it down to the specific zip code. We have that not just for COVID, but also for sexually transmitted diseases. I know that the 92103 zip code has more cases of syphilis, and therefore I need to be aware of that and test and treat this illness. I want testing and mapping for drugs. We should have mapping for overdose deaths, mapping for emergency department visits of agitated delirium due to drugs, and psychosis-associated marijuana. With 100,000 people dead a year from drugs, an entire airplane full of people falling out of the sky each day, we need real-time data to intervene better. Next, the infectious disease model includes treatment. All infectious diseases have treatment, antibiotics for Shigella, gonorrhea, and chlamydia, and monoclonal antibodies for COVID. Substance use disorder have treatment options as well, but yet only 12% of people with addiction seek treatment. Next comes tracing. We've heard of tracing when it comes to COVID, but the same concept can apply to drugs. Every overdose is a teachable moment. Let me share a case. 2 young women overdosed on fentanyl at a hookah lounge, and they came to the emergency department where they were treated for this fentanyl overdose. Luckily, they survived. But the hookah lounge needs a naloxone box and education. They thought the girls were just drunk and initially just called the police. The college where the girls go to school need education and prevention, and their friends and families may want to carry naloxone. Test, treat, trace. That has been the model for COVID, and it's important. But with all that, it's not as important as the vaccine. The vaccine offers the best protection. And the vaccine for drug addiction is prevention. If we can keep kids and young adults from using drugs of any type of addictive chemical until age 25, when the brain is done growing, then we would have less addiction in the country. Less nicotine addiction, alcohol addiction, and drug addiction. Most kids don't use drugs. They have no biological drive to use drugs. So we just need to protect those precious brains. If we want to be serious about drug prevention and deaths from fentanyl, then it starts with preventing marijuana use on that developing brain. I have not met a single patient who uses or overdosed on fentanyl that did not start priming his or her brain with marijuana at a young age. The LEV strategy to the drug problem would copy COVID with test, treat, trace, and vaccines. Test and track overdoses, treat addiction, trace to prevent further overdoses, and invest in prevention, the vaccine for substance use disorder. And now I am proud to introduce Admiral Rachel Levine, the 17th Assistant Secretary for Health for the United States Department of Health and Human Services, HHS, and head of the United States Public Health Service Commissioned Corps. The Admiral is a physician who worked in academic medicine and was Pennsylvania's Physician General and later Pennsylvania's Secretary of Health. She addressed COVID-19, the opioid crisis, behavioral health, and other public health challenges. You can find Admiral Rachel Levine's bio on the High Truth show notes. Admiral Rachel Levine, welcome to High Truths.
Well, thank you so much. It's a pleasure to be here.
And I trust that you adjusted to life in DC. I really enjoyed living there at the time. And you are the Assistant Secretary of Health. Can you tell us, what does that mean? What do you do?
Well, thank you so much for that question. So my role as the Assistant Secretary for Health is to advise the Secretary of Health and Human Services, Secretary Becerra, on public health matters, on medical and science matters, as well as to work to develop public health policy recommendations that really cut across health and human service agencies and operating divisions. I oversee the department's key public health offices and programs, a number of different presidential and secretarial advisory committees. We have 10 regional health offices across the nation. And then also, I oversee the Office of the Surgeon General and the United States Public Health Service Commissioned Corps. We work to respond to health challenges. We implement evidence-based initiatives. We work on policy. We foster health innovations. And our goals are to reduce health disparities, increase access and affordability of healthcare, and advance health opportunities for all. That health equity issue is very, very important to us.
That's a lot on your plate for the entire nation. You work on COVID, you work on drugs, you work at all health matters, and you're the boss of the Surgeon General.
So the Surgeon General and I work very, very closely together, and his office does report to the Office of the Assistant Secretary for Health, but I have a very collaborative leadership style.
I know that you're very passionate about the issues of addiction and drug overdoses, and HHS announced a new overdose prevention strategy that includes primary prevention, harm reduction, evidence-based treatment and recovery. And I want to have you expand on each of these as I share my infectious disease analogy. So, for example, I make the analogy that primary prevention for drugs is like the vaccine for COVID. So can you tell us what HHS is doing about prevention?
Sure. Well, we're all about prevention at the Department of Health and Human Services, and you are so correct. The overdose crisis is such a severe problem in the United States. It really is the crisis within the pandemic. So we, of course, want to prevent substance use and substance use disorders, and that is critical to how we address the overdose crisis. I'm a pediatrician and adolescent medicine specialist, and it's research shows that adults who have substance use disorders started using substances often in their youth or maybe as a young adult. So we have both a broad and targeted approach towards prevention. We want to focus on some population-specific strategies. We want to target high-risk individuals. It is, of course, multidisciplinary, and we use all of our surveillance activities on this as well. So we want to highlight substance use use prevention for youth and adolescents in schools. We want to use prevention efforts in communities. And one thing that I have worked on is working with the medical community on the careful and judicious prescription of powerful opioid medications. And so we have many different educational opportunities and efforts to work with the state and local health departments and work with many different provider groups on these prescriber and dispenser out-based efforts. All of our efforts will be evidence-based and, of course, implemented across the lifespan.
All important things. Yes, I've been involved as an emergency physician at the very beginning with the opioid prescription crisis. I think we've made a good headway, but you're absolutely right. I haven't met anybody who uses fentanyl or overdosed at fentanyl that didn't start at a very young age, sometimes like 9 or 10, which is alarming. And I feel like we can't fairly discuss prevention without addressing marijuana, especially on the growing brain. Is there a discussion about marijuana, mental health, and consumer protection?
Well, at the Department of Health and Human Services, we are continuously holding discussions about mental health and well-being of really everyone that we serve, everyone in the nation. Mental health is such a critical issue. And so there are lots of discussions about that intersection between mental health and substance use, and also particularly the intersection between mental health issues and physical health issues. There are reports from NIDA, the National Institute of Drug Abuse, on marijuana use among youth and college students. I want to highlight a study called the Monitoring the Future study, which has been done for decades, looking at the use of various substances in 8th graders, 10th graders, and 12th graders. We are seeing decreasing use of marijuana among high school students. But we are seeing a rise among college-age students. And so, we want to be very, very cautious about that. And of course, our priority remains including prevention and ensuring access to comprehensive evidence-based prevention and treatment.
Yeah, so I'm glad to hear that there's an effort. Again, in the emergency department, we provide a report once a year, and we're seeing really an alarming rise in cannabis-related diagnosis in the emergency department. In 2018, we saw 29 a day, and our new report card for 2019 will be 39 diagnoses a day, just in our county. And I think there is a big intersection, like you say, between mental health and substance use disorder, and we see that right in the middle. My infectious disease analogy for addiction treatment is like antibiotics for bacteria. So can you tell us about the treatment priorities and strategy for HHS?
Well, just like use of antibiotics for bacterial infections, and now, of course, the use of different therapeutics such as monoclonal antibodies for COVID-19, for substance use disorders, we always want to use evidence-based treatment. Evidence-based treatment is really key to addressing and treating patients with the disease of addiction and to reduce the number of people that die from drug overdoses. And that includes medications, particularly medications for opioid use disorder. They are really an evidence-based and key treatment. So in order to expand access to this opioid use disorder treatment, HHS did issue new practice guidelines for the administration of buprenorphine for treating opioid use disorder. This exempts eligible practitioners from the federal certification requirements for the quote-unquote XWaver related to training, counseling, and other ancillary services for the dispensing or prescription prescription of buprenorphine. We are supporting also research and development of new treatments and strategies for patients with substance use disorder. For example, for people suffering from the disease of addiction to methamphetamine or cocaine, there really is no current evidence-based standard of care medication for those disorders. So, we have to look at other types of behaviorally based treatments, including one called contingency management treatment. And we're also working, of course, on improving the delivery of this evidence-based treatment so that people have access and the availability for this cutting-edge evidence-based treatment for opioid use disorder and other substance use disorders.
I love hearing you say that. And I have a couple questions for you about that. Removing the barriers to prescribe buprenorphine is important, but they're still there. There's still this XWaver, and we had a campaign called Xing the XWaver. I think it's still it perpetuates stigma. Doctors could say, I can't treat that population. You need to have special, permission to do that. And can you imagine, like, if you have asthma and you say, I'm sorry, I can't refill your inhaler, you need to go to somewhere else. Majority of substance use disorder can be done at a primary care setting. Yes, there are some that need, to have a specialist, but it remains a barrier. Is there any movement to try to eliminate that?
Well, so yes, we are committed to removing barriers for people seeking access to addiction treatment, including, of course, medication for opioid use disorder, which is evidence-based in the standard of care. So that is why we published the buprenorphine practice guidelines. This was an integral step in addressing barriers from providers that we are hearing, that it required 8 hours of specific training for buprenorphine for physicians and up to 24 hours, actually, of training for physician extenders, such as nurse practitioners. And so we do support removing the XWaver. But as you know, this is something that we cannot do by regulatory action. This actually requires an act of Congress. This requires congressional action. But we want to remove all the barriers to care, including this issue in terms of buprenorphine prescriptions. And we do want to integrate the prescribing of buprenorphine medications for opioid use disorder into primary care practices. And we have a number of different programs to do that. I feel that this should really all be incorporated into medical school training and into postgraduate training. And in Pennsylvania, I did work with all of the medical schools in the state to accomplish that. And so we want to work throughout the country on that type of integration of this into physicians' regular training programs.
So, Admiral, you'll be pleased to hear I have 2 daughters in medical school, and they, from day one, got lectures on pain and addiction more than once. So I think that's happening. Contingency management for methamphetamine in the West Coast, we recently did a study, and 76% of all the drug screens that we obtained in our emergency department, 76% were positive for methamphetamine. So we desperately need removing the barriers to treat contingency management, which is effective treatment. Not everything needs to have a medicine. So anything you can do to help out with that would be really appreciated.
Absolutely. Thank you very much. We were certainly working towards that in a multidisciplinary way with our office, as well as, of course, SAMHSA, NIH, NIDA, and others.
So harm reduction, this is something new, a new concept brought by the federal drug strategy. Can you explain what that is and what does that mean? Is it naloxone and fentanyl strips? Is it safe consumption site? What is it? What does harm reduction mean?
Well, we're thinking of harm reduction very broadly, and it is a proactive and an evidence-based approach to reduce the negative personal and public health impacts of the behavior associated with substance use at the individual level and at the community level. And it's critical in terms of mitigating the negative consequences associated with drug use. So this does include continued work to expand the distribution and the administration of the life-saving medicine naloxone, often called Narcan. I worked on this extensively in Pennsylvania and was actually the first state health official to write a standing order prescription for everyone in Pennsylvania to be able to obtain naloxone from a pharmacy based upon my prescription. Again, as the state health official, we want to work across the country to have first responders have naloxone, but actually have the general public have access to this life-saving medicine. Another is access to what are called fentanyl strips. So you had mentioned fentanyl. These fentanyl-related compounds, illicit fentanyl-related compounds, are related to many, many overdoses, the majority of overdose deaths that we see in the country. These fentanyl substances, unfortunately, are very cheap, very easy to make, an extremely powerful opioid. And they sometimes people might find it by themselves, with just fentanyl. They might find it adulterating heroin. You might even find someone that might be using something such as methamphetamine or cocaine, but actually it's adulterated with fentanyl, which significantly increases the risk of overdose. So these fentanyl strips allow people with the disease of addiction that might be using to detect that there's fentanyl in them, which means that maybe they won't use the substance, or they'll take precautions such as using with someone else who has naloxone to make sure that lives can be saved. We also are strongly supportive of syringe service programs where people can get a variety of services. They can get clean kits in terms of using drugs, but they also can have access to fentanyl strips. They can have access to naloxone. They also can serve as a linkage to care, where people can get perhaps buprenorphine or get linked to treatment with buprenorphine. And they also are integral in preventing the infectious disease complications associated with substance use, such as hepatitis and HIV. So harm reduction is one of the four priorities, one of the four pillars of our overdose strategy to integrate to reduce overdoses across the country.
Very important four pillars, and agree with all of them, despite my infectious disease analogy. Naloxone, it has an expiration date, and there's still some barriers to getting that. Is there any talk with FDA as far as getting a generic version or extending shelf life, anything like that?
Well, I know that there have been. Yeah, I know that there has been work in terms of more preparations of naloxone. Currently, what we're using is the nasal preparation, which is really quite easy to use, for people, and accessible. The FDA has discussed about whether that would be over the counter or not. There are challenges to that, but they're working through. So we'll see what FDA decides in terms of their deliberative process. But what we want to work on at the federal government is to make sure that the states have access to naloxone to distribute throughout their states. We did this in Pennsylvania. In naloxone, we handed out in Pennsylvania. We handed out naloxone kits through our state health centers. We worked with the health departments of our cities, such as Pittsburgh and Philadelphia, and other county health departments to hand out naloxone. And again, people could get it with a prescription, and every insurance company in Pennsylvania did cover naloxone, including Medicaid. So we want to make sure that type of distribution and administration is available throughout the country. And we'll work with SAMHSA, we'll work with CDC, with HRSA, and our community health centers to accomplish that.
That's great. You mentioned fentanyl strips. I just want to share with you that in San Diego, we also worked on fentanyl testing in hospitals. When you get a drug screen and doctor gets a drug screen, you get, you test for marijuana and PCP and opiates and amphetamines. We also, since fentanyl is the number one driver of deaths, we wanted to include fentanyl because that makes a difference. So we did that in San Diego. Now it's standard of care. And hopefully for 2022, we'll have a bill in California that will make all hospitals include fentanyl in drug tests. So I wanted to kind of share that idea with you.
Thank you. That's very important because we need to know what substances are there that are leading to these overdoses and overdose deaths. One of the challenges that we see is that there are many, many different fentanyl-related compounds, and so the tests have to continue to evolve to keep up, actually, with the variations that we see. It poses a big challenge.
And so you just went through all the strategies, and, really thankful that there's so much attention to this effort. And I can't ignore that we're in the middle of a pandemic, COVID, new strains coming about. Your office is managing that. Anything you want us to know about living through this pandemic?
Sure. Well, the COVID-19 pandemic has been so challenging. I mean, everyone has felt the strain. And it has highlighted several lessons, I think, that we have to learn from the pandemic. One is that we are all interconnected. The decisions that any of us make have strong implications and really influence our families, our communities, our nation, and the world. And nothing is more important right now than getting vaccinated. We have safe and effective vaccinations. We have 3 safe and effective vaccinations, and we really, really want to encourage people to get whatever, if they're not vaccinated, to get whatever information they need. We will provide that, through the federal government, as well as state and local health officials and other medical professionals. To get vaccinated and start right now. We are facing the predominant strain in the United States, which is still the Delta strain, which is very contagious. And then, on the horizon is this new Omicron strain, and we're learning more and more about that every day. We have made so much progress in our vaccinations throughout the country, but we have more work to do. And then if you have been vaccinated, especially with the potential for Omicron spreading in the United States, it's very, very important to get boosted. And so follow CDC directions to get your and instructions in terms of getting your booster dose, which in more evidence is showing that provides the best protection against this new strain, Omicron.
And are you recommending boosters now for everybody or only a select part of the population?
Well, we're recommending boosters now for those 16 and above. So if you received the Pfizer or Moderna vaccine, you can get boosted 6 months later. If you received the Johnson & Johnson vaccine, you can get boosted 2 months later. I actually received the Johnson & Johnson vaccine in the late spring, and then got boosted the day that it was authorized by the CDC. And so we really want everybody now 16 and older to get boosted.
That's great. All right, get boosted, America. Admiral, working with families, communities around our country, what is it that you want us to do to make a difference in the issue of substance use disorders?
Well, I think that it is so important for us to get past the stigma associated with the disease of addiction. Addiction is a disease like many other diseases. It's a disease of the nervous system. And so we have to get past the stigma associated with that. And we also have to get past the stigma associated with using medications. We've talked about medication for opioid use disorder. The medications are not a crutch. They are a medicine. We use medicines to treat many medical disorders, such as diabetes and hypertension and high cholesterol and seizure disorders and many other types of conditions. So buprenorphine medications, methadone, and other medicines are medicines for opioid use disorder. And so we have to work past those stigmas in order to help people suffering from the disease of addiction.
Right. If you have a medical condition, then there shouldn't be stigma associated with that. You should be able to get help. But we also want prevention. We don't want people to end up with this disease in the first place when possible.
You're entirely correct. I agree 100%.
Yeah. So Admiral Levine, what an absolute honor to have you here on High Truths and learn that our federal government is committed to fixing the terrible devastation that drugs have on our country. And I know and feel that you are passionate on the issue. I so appreciate your kindness. I noticed that on Zoom conferences, people in positions of power can be aloof, but you've always addressed me and others with humility and care. And I really thank you for your passion and commitment. And I bless you with success on this very important mission.
Thank you so much. I really, truly appreciate that. And it's really been a pleasure to be here.
Thank you for listening to High Truths on Drugs and Addiction, where national experts bring you facts and answer your questions. This High Truths podcast is sponsored by CCR, the Center for Community Research, enhancing public health and safety through informed action. CCR is a San Diego-based nonprofit organization that has been recognized at the state and national level for community work on opioids, prescription drugs, methamphetamines, youth marijuana prevention, and data evaluation. Learn more about CCR at ccrconsulting.org. Our producer is Dave Rivas from Davey Boy Productions. I am your host, Dr. Ronit Lev. We hope we brought your day a little bit more high truths.